Welcome to the CME program titled New Guidance to Diagnose and Treat Tumor-Induced Osteomalacia. This program is supported by an educational grant from Kyowa Kirin. I'd now like to turn the program over to our faculty educator, Dr. Aliya Khan of McMaster University.
Hello, everybody. My name is Aliya Khan, and I'm a clinical professor of medicine at McMaster University, and it really is my pleasure today to speak to you about tumor-induced osteomalacia. And these are my disclosures. I wanted to say that we recently published global guidance for the recognition, diagnosis, and management of tumor-induced osteomalacia in 2022. And I'll begin with a case. So I wanted to present a case of a 55-year-old man who came to our clinic, and he had been feeling weak and generally not well. And what was really quite striking was the muscle weakness that he noticed. And he was also having knee pains and pain in his hips and his feet. When he first came, the first assessment that he came, he was actually using a cane for support. And a month later, he came using a walker. And then after that, he came using a wheelchair. So within a course of 2 to 3 months, he went from a cane to a wheelchair. So the muscle weakness can be quite dramatic, and it can be quite progressive and significant over a short time period. Now, what is tumor-induced osteomalacia? It is a rare condition. It's a paraneoplastic condition, and it's associated with an increase in FGF23 being secreted by mesenchymal tumors. These tumors are usually benign, but they can be anywhere in the body. They can be small. They can be difficult to locate. Tumor-induced osteomalacia has also been reported in individuals with advanced metastatic cancer, such as colon and prostate. It results in significant muscle weakness, bone pain, and fractures. These are the typical presenting symptoms. And there is usually a delay in diagnosis, often for several years, because people are not checking phosphate. So if we don't check phosphate and we have a patient with muscle weakness and bone pain, patients may have the vitamin D levels checked. They might check 25D, which is usually normal. And so the diagnosis may be completely missed. So one of the important points that we wanted to highlight in this recent publication, and has been highlighted in other publications as well, is the importance of checking phosphate in people who present with muscle weakness and bone pain. 95% of patients with tumor-induced osteomalacia are initially misdiagnosed. And they may be misdiagnosed as having arthritis, which may be present as well. Arthritis is common. So yes, patients may have osteoarthritis. They may also have rheumatoid arthritis. They may have other conditions that can be associated with MSK features. Or they may have tumor-induced osteomalacia in isolation as the cause for their symptoms. They're also often misdiagnosed as having neurologic or muscular disorders such as polymyalgia rheumatica, multiple sclerosis, and functional somatization. These are commonly seen as misdiagnoses. And I've had young people, especially young women, who have been referred, and the diagnosis is, it's fibromyalgia. And it's clearly not, because nobody bothered to check the phosphate. So remember, we have a phosphaturic mesenchymal tumor, which can release FGF23. FGF23, fibroblast growth factor 23. And this is a hormone which will decrease the sodium phosphate cotransporters in the kidney, and thereby decrease phosphate reabsorption in the proximal renal tubules. And so we have a renal phosphate leak. It also decreases the 1-alpha hydroxylase activity. And so the formation of 125D is decreased, and it increases the 24 hydroxylase activity so that catabolism is increased. And so we have a reduction in 125 dihydroxyvitamin D levels, and that will decrease the absorption of both calcium and phosphate from the bowel. And both of these effects, the renal effects and the GI effects, result in a decrease in serum phosphate. Now, calcium and phosphate binds to the osteoid to form normal bone mineralization, to allow that bone to mineralize. And so if the calcium phosphate product is abnormal due to inadequate levels of phosphate, then we will not be able to mineralize the bone, and we will have osteomalacia, we can have bone pain, fractures, and significant muscle weakness. When we have a patient with hypophosphatemia, we are looking at two possibilities. This is either acute or it could be chronic. So acutely, we can have short-term changes in phosphate due to intracellular, extracellular shifts of phosphate. But if our patient has chronic hypophosphatemia, it's usually due to inadequate intake or malabsorption. And malabsorption could be because of small bowel disease or bariatric surgery or inadequate levels of vitamin D or phosphate binders. And in these situations, the TMP-GFR, or the tubular maximum phosphate adjusted for GFR, is high or normal. So we have enhanced renal phosphate reabsorption to accommodate for the fact that our patient has low phosphate levels due to inadequate intake or malabsorption. Now, our patient may also have renal phosphate wasting, and they may have a leak in the kidney. And in these situations, the TMP-GFR is low, and we can calculate the tubular maximum phosphate adjusted for GFR, and this is low. So the level at which phosphate is leaked through the kidney is very low, and this is the cause for the hypophosphatemia. So what is FGF23? This is fibroblast growth factor 23. It's a bone-derived hormone, and it regulates phosphate homeostasis and vitamin D metabolism. And when we have high levels of FGF23, it decreases renal phosphate reabsorption, and it also decreases renal phosphate absorption from the bowel by decreasing the formation of 125D. Just wanted to say a few words about renal phosphate transport. 60 to 70% of renal phosphate reabsorption happens in the proximal convoluted tubule, and the major regulators are PTH and FGF23. And both of these hormones have a phosphaturic effect. Minor regulators are PTHrP, calcitonin, atrial natriuretic peptide, acidosis, and steroids, and these also inhibit phosphate reabsorption. Now, the rate of phosphate transport depends on the abundance of the sodium phosphate cotransporters, as well as the magnitude of the sodium gradient across the luminal membrane. And phosphate entry into the renal epithelium is via the sodium phosphate cotransporters. So we can have mutations in the solute carrier family gene, which can result in a decrease in the sodium phosphate cotransporters, and this can be a mechanism independent of FGF23. So how do we diagnose tumor-induced osteomalacia? Well, first of all, we think about it if a patient has MSK pain or weakness, multiple fractures, fatigue, or a palpable localized mass. Usually you need to search for this palpable localized mass. But by history, we're going to ask our patient, how long have you noticed the presence of weakness, muscle weakness, difficulties with balance, difficulties with walking, difficulties with fatigue? And in tumor-induced osteomalacia, patients will say, you know, I was feeling really great 10 years ago. 5 years ago, I was good. Maybe in the past few years, I haven't been feeling well. They might not be able to even give that type of a clear-cut history. We have to prompt them and ask them, how were you feeling 10 years ago or 5 years ago or 2 or 3 years ago? Now, if we have a young person, a teenager or a young adult, we always ensure that there isn't a genetic cause for the hypophosphatemia, because genetic causes may have a subtle presentation and the patient may not have recognized these symptoms. So always do a DNA analysis looking for the genes that can cause hypophosphatemia, and don't assume that it is tumor-induced osteomalacia. And remember, you might not get a positive family history. If there is a family history of, hypophosphatemia or bowing of the lower extremities, or they have been problems with skull, and there are other features to suggest a genetic cause for hypophosphatemia, such as dental problems, then, that's really great, but that may not be present, because patients 10 to 20% can have a genetic cause and be a de novo mutation. So you may or may not develop that, have that family history to confirm that the patient has a genetic cause for the hypophosphatemia. When we examine our patients, we're looking at height, we're looking at body proportions. Why? Because we want to ensure that we're not overlooking X-linked hypophosphatemia or another genetic cause for hypophosphatemia. And in patients who have a genetic cause, there is bowing of the lower extremities because of rickets and osteomalacia, and the limb deformities will develop. Craniofacial abnormalities such as frontal bossing or craniosynostosis with premature closure of the cranial sutures can happen. We should do a dental and oral cavity examination. We're looking for abscesses and periodontitis. And we do recommend palpation of the entire body for masses. Tumor-induced osteomalacia, these tumors can be very, very small. And it could be anywhere in the body, from the head to the toe. We need to ensure that there are no palpable masses. We measure phosphate. It should be a fasting phosphate. And I tell my patients to get their blood work done fasting at 8 a.m. and have the phosphate done. And then at 10 a.m., I ask them to give a urine specimen, which will be a complete void at 10 a.m. So they're at home at 8 o'clock, they urinate, flush, and now their bladder is empty. They go to the lab, have their blood work done, fasting phosphate, and then at 10 o'clock, they give a urine. They do a void, which will be like a 2-hour void from 8 o'clock. And we use that blood and that urine to calculate the tubular maximum phosphate reabsorption adjusted for GFR. So it's a second morning void for urine phosphate and urine creatinine, and it's a fasting blood specimen. We're also going to be measuring bone, specific alkaline phosphatase, as well as total alkaline phosphatase, PTH, both of the vitamin D assays. And if your center has FGF23 available, then we recommend that that be evaluated. Genetic testing is important, and it is essential, really. I would say that in everybody, I would do DNA analysis to ensure that there isn't a genetic cause for the hypophosphatemia. And then we would go on to functional imaging. Now, in a general practice or a general internal medicine practice, or a general endocrinologist or a general rheumatologist, you may wish to refer your patient to a specialized center to ensure that the genetic testing is done and the appropriate imaging is completed. So what is the differential diagnosis of hypophosphatemia? Well, it could be FGF23 mediated, or it could be non-FGF23 mediated. So if we look at FGF23 mediated, we could have autosomal dominant hypophosphatemic rickets due to mutations in the FGF23 gene. It could be autosomal recessive hypophosphatemic rickets due to mutations in these genes. It could be cutaneous skeletal hypophosphatemia syndrome due to these mutations, or fibrous dysplasia of bone due to a GNAS gene mutation, or Jansen's metaphyseal chondrodysplasia due to mutations in the PTH1 receptor gene. It could be acquired because of alcohol, excess alcohol. It could be because of iron infusions, which can result in increases in FGF23, or it could be tumor-induced osteomalacia. So do ask about alcohol excess and have they had recent iron infusions. Now, non-FGF23 mediated. In these situations, we have a low phosphate, and this is renal phosphate wasting. So there is a low TMP-GFR, but it is not FGF23 mediated. And in fact, FGF23 is low. And it could be HHRH, which is hereditary hypophosphatemic rickets with hypercalciuria. And this is due to mutations in the solute carrier gene. And this results in a reduction in the sodium phosphate cotransporters. So there's a leak of phosphate. And because the phosphate is low, then FGF23 is decreased. And because FGF23 is decreased, we have elevations in 125D. Because FGF23 decreases 1-alpha hydroxylase activity. So we've got 25D becoming 125D, and we have an increase in 125D production. With hyperparathyroidism, primary hyperparathyroidism, we do have a phosphaturic effect, and it is important for us to evaluate PTH levels. We can have it with idiopathic infantile hypercalcemia, and it can also happen with renal Fanconi syndrome. So these are conditions that we need to exclude. And also, we need to ensure that our patient does not have a vitamin D deficiency or abnormalities in vitamin D metabolism. Malabsorption, malnutrition can also result in hypophosphatemia. And as we mentioned, we can have low dietary intake. It could be because of abnormalities in absorption, because of small bowel disease. It could be because of phosphate binders, antacids containing calcium, magnesium, aluminum, or sevelamer. Alcoholism is associated with hypophosphatemia. And in premature infants, we can see hypophosphatemia. So transcellular shifts, we talked about this, and this can result in acute changes in phosphate. And then there are a number of drugs that can cause hypophosphatemia. It is important for us to ensure that our patients are not taking these medications, as they can result in low phosphate levels. So if we have a patient who has muscle weakness, difficulties with gait or balance, or bone pain, we do need to take a very careful history, try and identify when these symptoms began, ask about a family history of limb abnormalities, craniosynostosis, dental abnormalities that would suggest that the patient has XLH or other genetic mutations that can result in hypophosphatemia and renal phosphate wasting. And remember, de novo mutations may be present and the family history may be negative. So oftentimes it can be a diagnosis of exclusion, but any patient presenting with muscle weakness, pain, fragility fractures, or bone pain should be evaluated with a serum phosphate. And if it is low, it should be repeated, and further lab profiles should be completed. This is how we calculate tubular reabsorption of phosphate and the tubular maximum phosphate reabsorption adjusted for GFR. So we look at the urine phosphate and multiply it by the plasma creatinine. And remember, everything has to be in the same units. So it's all in millimoles per liter. And then we divide it by the urine creatinine times the plasma phosphate. So this is one of our patients who had presented with hypophosphatemia, chronic hypophosphatemia, and we will calculate like we do the calcium to creatinine clearance ratio, we're going to do the phosphate to creatinine clearance ratio. This gives us the phosphate to creatinine clearance ratio. Then the tubular reabsorption of phosphate is 1 minus the phosphate to creatinine clearance ratio, which in this patient is 0.795. And then we would calculate tubular maximum phosphate reabsorption adjusted for GFR. And that would be tubular reabsorption of phosphate times the serum phosphate. So in this patient, it's clearly low. And these are the normal values for women and for men. Now, patients who have hypophosphatemia can develop hyperparathyroidism. And when would they have hyperparathyroidism? Well, they can be secondary stimulation of the parathyroid glands because of low 125D. And in patients with tumor-induced osteomalacia, one of the mechanisms for hypophosphatemia is a low 125D. So the low 125D will stimulate the parathyroid glands and increase PTH release. When we start treating our patient and give them phosphate supplements, that can further stimulate PTH levels. High FGF23 stimulates PTH. And then when PTH becomes high, it further increases urine phosphate losses, and it also increases FGF23. So it becomes a vicious cycle. So when we suspect TIO, it's very important to measure phosphate, consider genetic testing for patients to ensure that they don't have conditions associated with a genetic cause for hypophosphatemia. Ask about personal and family history of short stature, lower limb deformity, and extensive dental abnormalities, and proceed with DNA analysis. When we examine our patient, we look at their height, we look at their body proportions. It is important to evaluate sitting height, and usually if there's a genetic abnormality, the sitting height is maintained, but it's the standing height that's abnormal because of lower limb deformities. Look for craniofacial abnormalities, do a dental and oral exam, and palpate the entire body looking for masses. And in the presence of an unclear diagnosis, perform lab assessment, further assessment. So the biochemical features of tumor-induced osteomalacia are a low phosphate. Alkaline phosphatase is increased because of osteomalacia. Serum calcium can be decreased because low 125D levels decrease the absorption of calcium and phosphate. Or it may be normal. Intact FGF23 can be increased, or it may be inappropriately normal. And the C-terminal FGF23 may be increased. Intact PTH may be normal, or it could be increased. 125D levels are decreased, or they may be inappropriately normal. And 25D levels are usually normal. So if you don't measure phosphate and you don't measure 125D, you might totally miss the picture. And if the 125D is normal inappropriately, then you've also missed the picture. This is the reason why tumor-induced osteomalacia is missed. The diagnosis is missed because people usually don't check phosphate and don't check 125D. And we need to calculate TMP-GFR. And in tumor-induced osteomalacia, it is decreased. And tubular reabsorption of phosphate is decreased. But if you don't calculate it, then we won't know. So how do we treat it? Well, there is medical and surgical intervention. If we identify the tumor, we should definitely proceed with surgery. But usually we need to implement medical therapy right away because these patients do have significant hypophosphatemia. So conventional therapy consists of phosphate and active vitamin D. And phosphate needs to be given multiple times during the day because it has a short half-life. And it's important to remember that when we give phosphate, it can increase PTH, as we've mentioned. And phosphate can increase ectopic calcification. So we never want phosphate levels to be high. we also want to ensure that the risk of nephrocalcinosis is not increased by ensuring that we're not giving excess phosphate. Calcitriol can be given as well. Calcitriol is twice as potent as alpha calcidol. And you can begin at 0.25 micrograms. If the hypophosphatemia is mild, just give it 2 or 3 times a week. Or you could then go to 0.25 micrograms once a day or 0.25 micrograms twice a day. It does have a short half-life, 6 to 8 hours. So BID dosing is optimal if the requirement is more than 0.25 micrograms a day. And because the half-life is short, remember steady state is achieved in 5 to 6 half-lives. And so check the levels of phosphate, in 3 days. You don't need to wait 3 months to check it again. You might overshoot or undershoot. So check that level in 3 days. And if we give alpha calcidol or calcitriol, this can also increase FGF23 and increase the risk of nephrocalcinosis. Phosphate and calcitriol do have GI side effects, and it is important for us to recognize that giving back phosphate will further stimulate the parathyroid glands and increase PTH synthesis and secretion. So the medical management consists of oral phosphates, salts, plus active vitamin D, and we can also give burosumab. So if it's not a mild leak, our patient may require high doses of active vitamin D and phosphate salts and might not be able to tolerate them. And we will then switch over to burosumab. We do not give phosphate and active vitamin D with burosumab. We would switch. And then on burosumab, we need to monitor our patients carefully every 3 to 4 months, checking their serum and urine calcium, their serum phosphate, and obviously the urine phosphate as well, because we want to ensure that we're monitoring TMP-GFR. We need to monitor their renal function, parathyroid hormone, and the alkaline phosphatase levels. And every few years, we do recommend monitoring the kidney with renal ultrasound, ensure that we don't have nephrocalcinosis or nephrolithiasis. And we would also be doing imaging to determine if we are able to localize a tumor. Now, another medical option that is value in patients with tumor-induced osteomalacia is cinacalcet. Now, this is a schematic illustration of the chief cell in the parathyroid glands. And calcium binds to the calcium sensing receptor and decreases the synthesis and secretion of PTH. Now, if we have a patient with tumor-induced osteomalacia who has developed secondary or tertiary hyperparathyroidism, then we need to consider the fact that we might be able to reduce PTH synthesis and secretion by giving a positive allosteric modulator of the calcium sensing receptor. And cinacalcet is a positive allosteric modulator. It increases the sensitivity of the calcium sensing receptor to calcium, and it lowers the threshold for calcium to decrease PTH. This is the phase 3 double-blind randomized controlled trial study that we did in primary hyperparathyroidism. And we started the dose of cinacalcet at 30 milligrams twice a day and increased it to a maximum of 90 milligrams 3 times a day. The important point to note is that this study was done in patients with primary hyperparathyroidism, and we need to have a similar study in tumor-induced osteomalacia. But clearly, the drug is effective and it decreases PTH. And what it will do is, because PTH is coming down, we are now able to reabsorb phosphate through the kidney, and phosphate levels rise. And the TMP-GFR will improve. So the only way that we can improve the TMP-GFR is with burosumab This is what burosumab does, is it binds FGF23. And so because it will bind to FGF23, it will result in an increase in the 1-alpha hydroxylation, and it will normalize 125D levels. It will normalize the calcium and phosphate absorption from the bowel, and it will increase the expression of the sodium phosphate cotransporters and allow sodium phosphate cotransporters to be expressed abundantly, and phosphate reabsorption through the kidney will normalize. So how do we treat it? Non-surgically, phosphate salts and active vitamin D. And we recognize that cinacalcid is a calcium mimetic agent that decreases PTH, but it requires further study in tumor-induced osteomalacia. Burosumab is the only FDA-approved therapy for tumor-induced osteomalacia. So burosumab was demonstrated to improve bone mineralization with reductions in osteoid volume over bone volume and osteoid thickness, as you can see. There was a reduction in the mineralization lag time and in the osteoid surface over bone surface. Fracture healing also improved with tumor-induced osteomalacia. To proceed with burosumab therapy, we will be closely following these individuals. If we identify the tumor, then we can go ahead with surgery because surgery is curative. And while they're having their surgery, we would follow them and ensure that we're monitoring the lab profile every 3 to 4 months, measuring phosphate, serum, and urine, and also look at urine calcium and serum calcium. Once we have the diagnosis of tumor-induced osteomalacia, we do functional imaging and also proceed with anatomical imaging with MRI and CT. And we can use gallium-based functional imaging with PET or PET-CT gallium dotatate scanning, or copper-based PET-CT. And these are very useful and definitely a value over the octreotide scan. So the treatment is to initiate medical therapy with oral phosphate salts plus active vitamin D. Once we've got the diagnosis, we want to completely resect the tumor and ensure that we have tumor-free margins for ideal response if we want to reduce the risk of recurrence. And in patients with confirmed TIO, with unresectable, or we didn't find the tumor, we should proceed with oral phosphate salts plus active vitamin D or burosumab. It's not and, it's or. Okay, so we do recommend following these people every 3 to 4 months, and we recommend that for patients with unresectable tumors that have been identified on imaging, that they be followed every 1 to 2 years. Now, remember, tumors can recur. And we had a patient, this patient that I presented, actually, he did have recurrence. And so it's very important to get complete tumor removal with wide resection margins. In our patient, we actually had a tumor in the ethmoid sinus, and it did recur. So these tumors can be in very difficult locations, and they can have recurrence. And treatment can result in significant improvements in quality of life, muscle weakness, fatigue, and bone pain. So it's definitely going to make a big difference in our patients' management. So to just end with some clinical pearls, tumor-induced osteomalacia is a very rare condition. New guidance is available in our international paper. The key factor is we need to identify and diagnose tumor-induced osteomalacia to raise awareness amongst physicians that they should be checking phosphate, especially in patients who have weakness and unexplained bone or muscle pain. And think about it in patients in whom we have symptoms that are out of keeping with the clinical picture. Surgical and non-surgical treatment options are available, and quality of life is poor in these patients. We do need to improve our understanding of tumor-induced osteomalacia and standardization of the patient pathway, as well as the diagnostic assays and treatment modalities. and we expect to improve the outcomes in the near future. And so with that, I'd like to thank you for your attention, and I hope you enjoyed the program.